Brain neoplasms number 9, prepared by Prof. Sharaf and revised by Prof. Rami Edward, will be concerned with some pediatric brain tumors. We will divide them into two big groups. The congenital brain tumors in infants younger than 60 days old, and here you put teratomas, primitive neuroectodermal tumors, astrocytoma, choroid plexus papilloma, ependymoma, medulloblastoma, and medulloepithelioma, germinoma, angioplastic meningioma, and ganglioma. So they are mainly gliotic with some medulloepithelial tumors and choroid plexus tumors, but the main are the congenital brain tumors, teratoma, and the primitive neuroectodermal tumors. Sometimes medulloblastoma is considered amongst these. In the posterior fossa, we have the medulloblastoma and astrocytoma and ependymoma, but we must remember that hemangioblastoma is the most common primary cerebellar tumor in adults. This is the appearance of teratoma. It is a deformed brain. That means malformed brain. It appears as heterogeneous masses with bossy outline swimming in CSF. You might be able to see a brain stem which is atrophic and represented by a cord-like structure. Teratoma. Peanut. It can be glial or neuronal. Within the cerebral hemisphere or supracellular region, they are seen as large, well-demarcated heterogeneous masses with both solid and cyst-like areas within the deep cerebral white matter. Calcification is very common and solid parts enhance. Some consider the medulloblastoma and the ependymoblastoma and the pinealoblastoma and the retinoblastoma among Bennett. And we have the second group, or the DNET, or the desmoembryoplastic neuroepithelial tumor. DNET, desmoplastic tumor, is peripheral in location, involves the gray matter, and presented soap bubble appearance. It can present pressure erosion on the nearby skull, cranium. Calcification may occur in 5% of cases, and surrounding vasogenic edema is absent. Enhancement is minimal. So DNET appear as large, well-demarcated heterogeneous masses within the cerebral hemispheres. Calcification is common, solid parts enhance, and all blastomas are included as subcategories sometimes, but on the other hand, the neuroepithelial desmoembryoplastic is a sort of gray matter malformation, and this occurs usually peripherally, not enhancing, and no vasogenic edema, and it's called DNET. So we have PNET in the center and DNET at the periphery. PNET represents either glial or neuronal cells. DNET presents usually neuroepithelial cells. PNET are large, usually some enhancement, and the calcification is very common. DNET will not enhance and may show calcification only in 5% of cases. Now this is the example. A supratentorial large mass with calcification and surrounding edema reaching to the periphery, but it's mainly the main bulk is within the hemisphere. As we said here, there is heterogeneity, and both sides, both solid and cystic areas appear, plus calcification and some enhancements. So if we say calcification, yes; solid and cystic, yes; heterogeneity, yes; and minimal, some pathogenic edema is seen, yes, but it's minimal. Center of the brain, hemorrhages can occur, and these are the DNET. Here we have something peripherally situated underneath the bone. It's cortical, sharply circumscribed, non-enhancing, multiseptated, hyperintense masses, and this is desmoplastic reaction, desmoplastic tissue, malformed tissue. So to gather up these three, we have the teratoma, which is malformed brain with atrophic brain stem, heterogeneity, minimal enhancement, minimal calcifications, passed within CSF, DNET central brain, central hemisphere, solid and cystic, calcification and hemorrhages, and so on. It's an aggressive form of tumor. DNET is less aggressive, it is just a dysplasia, and here no enhancement, and it is peripherally situated as the gray matter, and of course vasogenic edema is absent. So this will be something central, surrounding edema, showing some hemorrhages, some calcifications, and heterogeneous enhancement in T1 weighted images, and at the same time part solid, part cystic. So this is supratentorial DNET, while this one is cortical in location, no edema, no significant edema surrounding, and enhancement is minimal. This is after contrast enhancement. So this is DNET, flare, T2 and T1 with contrast. Atypical teratoid-rhabdoid tumor, something in between teratoma and rhabdoid tumor. This is 2% of CNS tumors. Most patients less than 5 years of age. Highly malignant from the name as it implies. About half of the tumors arise in the posterior fossa, mimic the appearance of medulloblastoma, extends into adjacent cerebellopontine angle system, a feature rarely seen in medulloblastomas. So the only thing to differentiate from medulloblastoma that it may extend into the cerebellopontine angle system. Here is the tumor, posterior fossa rhabdoid tumor, 20 months baby, with left facial paralysis and enhancing left cerebellopontine angle. Tumor with enhancement at the left cerebellopontine angle, destruction of the part of the apex with evidence of facial paralysis. Its diagnosis is posterior fossa rhabdoid tumor. Atypical rhabdoid tumor, right thalamic rhabdoid tumor. It is in the region, centered at the region of the right thalamus. In T1 weighted images, it shows cysts, necrosis, and this appear in T2 as areas of hyperintensity, and the tumor is possy outline showing necrosis and central necrosis and possy outline. And it causes compression of the third ventricle with dilatation of the both lateral ventricles. It's called atypical teratoid tumor. It is centered at the region of the thalamus, near to the third ventricle. Within the ventricle, definitely enhanced, may be calcified, is papilloma, with increased production of CSF, and thus there is dilatation of the ventricles. Another one, filling the posterior horn of the left lateral ventricle with enhancement. So it's a large intraventricular lobulated mass. So you can say that main intraventricular tumors are papillomas and malignant papillomas or carcinomas. Large intraventricular lobulated mass in the left lateral ventricle with showing intense enhancement and of course associated hydrocephalus. So this is choroid plexus papilloma, another case within the fourth ventricle. It can occur anywhere. It can occur within the fourth ventricle, as the same will happen. So differential diagnosis of the intraventricular tumor is to a less extent meningioma, but papilloma is main. Ependymoma is most common. Overproduction of the CSF causes hydrocephalus. Calcification in the choroid plexus papilloma result in hypointensity, and it is common. Choroid plexus papilloma. This is the one. This one is showing large size, and we have to see that the developing hydrocephalus is very big. The frondy appearance is with carcinoma rather than papilloma. Frondy appearance is with carcinoma rather than papilloma. Choroid carcinoma, of course, it being carcinoma, it will not be confined to the area where it is, so it will expand, invade, and causing associated vasogenic edema. So this is an invading intraventricular tumor mainly, but it is invading into the brain. Of course, there is associated compression on the lateral ventricle due to the mass effect, and hydrocephalic changes seen as dilated right lateral ventricle. Another mass replacing the posterior horn of lateral ventricle with marked vasogenic edema invasion into the brain, and it is mainly involving the lateral ventricle on the left side. There is shift of midline structure to the right. If you succeed to visualize involvement of the ventricle, so this will be essentially an intraventricular tumor which invades the brain, and thus the diagnosis of choroid plexus carcinoma is to be postulated, and the intense enhancement is with choroid tumor rather than others. Now in this case we have this Neuroblastoma deposits along the meninges, and we remember that among the tumors of the infants below 60 days, younger than 60 days, there is the retinoblastoma, and retinoblastoma is a part of the disease that involves the neurons and is a malignant process. And if it is neuroblastoma and not retinoblastoma, it will invade the meninges as this appearance with enhancement. Thank you.